this afternoon or evening or morning, depending on your time zone. We are talking about a particularly difficult drug to stop, which is Cymbalta or duloxetine. We'll be talking about the best way to approach coming off of it and some of the troubles that arise, some of the options to manage those troubles. And in this discussion, I'm joined by Maria Pastoor, who is more than a black box. She's been a moderator with the Facebook group Cymbalta Hurts Worse since 2020. There you go, you can see her face. Which is a huge group with tens of thousands of people getting advice on how to safely stop Cymbalta or duloxetine. She tells me that she is excited by the advances in deprescribing research in recent years, but still sad that so many continue to suffer at the hands of antidepressants and coming off them. And interestingly, in her life outside of Cymbalta Hurts Worse, she served as an attorney in the state of Minnesota, where she represented many battered women escaping from their abusers. And later in her legal career, she was a child support judge serving the first judicial district in the state of Minnesota. And we're very happy to have Maria here today. Do you want to say hello?
Yes, I wish I was more than just a black box or a stationary photo, but I'm glad that I'm able to hear everybody and that. So here I am. Hello, good afternoon or morning, wherever you happen to be.
Great to have you with us, Maria. I think the slides have dropped off. Can they be rejigged? If not, I will share them from my side. Give me 1 second. So I'll talk. No, here they are. So I'll talk for a few minutes about what is known about safely stopping Cymbalta or duloxetine, and then me and Maria will have a little bit of a discussion about some of the details, especially what she's learnt in moderating the Cymbalta Hurts Worse Facebook group over the last few years. So I guess the context for this entire discussion is that many people, at least tens of thousands and probably hundreds of thousands of people, find that their clinicians, their doctors, their nurses, their pharmacists don't know how to safely stop antidepressants. And that is because of a lack of education for years, because of really a lack of attention by researchers, because most of the studies are produced by drug manufacturers. There's been very little attention paid on how to stop these drugs, which means guidelines offer scant or poor or no really good advice on how to stop these drugs. And as a result, social media sites and peer support groups have really stepped into the fray to take up the slack. And so dozens and even hundreds of good citizens out there have taken it on their backs to help other people come off their drugs. And one very famous peer support site is Surviving Antidepressants, started by Adele Framer, who's part of the Outro team. But there are many private Facebook groups where people congregate to get advice on how to safely come off their medications. And I should say, I have a PhD in how antidepressants work from one of the top institutions in the world. I trained I did part of my training in psychiatry and medical school, but I learned how to come off an antidepressant from the website Surviving Antidepressants. So I owe a great deal to these social media sites. I've learned a lot from them. Um, uh, and there's dozens of Facebook groups, and one of them is Cymbalta Hurts Worse, which focuses on Cymbalta, which is a particularly difficult drug to stop. Next slide. So to focus on Cymbalta or duloxetine in a bit more depth, a few basic parts of the pharmacology. It is a serotonin and noradrenaline reuptake inhibitor, so that it affects both serotonin and noradrenaline by blocking the transporters that remove those neurotransmitters from the cell. It has some weak effects on dopamine as well. It has a very high risk of withdrawal compared to other antidepressants. There was a very good study done using the World Health Organization adverse effect reporting system. I think it's probably the best study that's been done so far. And there were 4 antidepressants that were well heads and shoulders above the others in terms of risk of withdrawal, and they were venlafaxine or Effexor, desvenlafaxine or Pristiq, paroxetine or Paxil, and duloxetine or Cymbalta. So these drugs are particularly hard to stop. In fact, in this analysis, the opioid buprenorphine had a similar risk of withdrawal as these drugs. In other words, some of these drugs are as hard to stop as opioids. And I know in my clinic that I run in London that patients who have been both addicted to opioids like heroin have told me it has been harder to come off antidepressants than heroin. So I'm not surprised to see this in this study. There are not great studies looking at how common withdrawal effects are from duloxetine as a percentage, but in a couple of studies that exist, after just 9 weeks of duloxetine use, about 1 in 3 people had withdrawal effects, and after longer term use, it was 2/3. The exact numbers are not known, but there's a relationship between duration of use and risk of withdrawal. So by the time people are using these drugs for 5 or 10 or more years, which is more and more people, we know that a large proportion of people will have trouble coming off, and many people will have severe trouble. I can't in my mind think of a single person who's been on duloxetine that I've seen for several years and has had no trouble coming off. They may be out there occasionally from my colleagues. I hear that they exist, but I personally have never encountered such a person. The drug is removed from the body fairly quickly. It takes about 12 hours for the drug to be removed. That may be part of why withdrawal effects are so severe, or it may be because it affects so many different receptors we don't quite know. And I'll probably talk about this point on the next slide. If you go to it, Brandon, I'll talk about linear tapering in a moment. So to give a general overview of what is happening with withdrawal symptoms, this is kind of a cartoon to try to show what happens. Basically, when you start the drug, which is given with blue dotted lines here, it rises, the blood levels rise in the system, they reach a steady state, and the brain adapts to the levels of the drug. That's the black line. So our brain and our body obey the law of homeostasis, which basically means it likes to stay in the middle. So when it's too hot outside, we sweat. When it's too cold outside, we shiver. We try to keep in the middle of things. And so when a drug increases levels of serotonin and noradrenaline, our brain responds, and our body, because of course these drugs affect every cell in the body, not just the brain. Our brain and body respond by becoming less sensitive to these chemicals, in the same way as your eardrum becomes less sensitive to noise when you're in a very noisy concert to try to keep things in the middle. And you can see changes in serotonin receptors in the brains of people given antidepressants after just a few weeks. And we know that when people stop antidepressants, there are brain scans that show there are changes to the serotonin system that last for up to 4 years after antidepressants are stopped. In other words, the brain adapts to these drugs, and those adaptations take a long time to go away, to resolve. And that's probably why withdrawal symptoms can last so long. So in this diagram, you start the drugs, and actually I should say one thing, just take one step back. Sometimes people, when they hear that antidepressants increase serotonin or noradrenaline, they're told that these increases in these transmitters normalizes an underlying deficit. That is, that in depression or anxiety, there's a lack of serotonin or noradrenaline, and so these drugs that increase those levels are normalizing those chemicals. But I think there is now wider understanding that that's not the case, that in studies that have looked at people with depression or anxiety, there's no clear evidence of lower serotonin or noradrenaline, and really that was very much a marketing line that came out of drug companies to encourage people to take medications that would increase serotonin and noradrenaline. So in the brains and bodies of people with depression or anxiety, they have the same as everybody else, normal levels of serotonin and noradrenaline. And so when a drug is introduced that increases those levels, it generally produces artificially high levels of those medication, of those drugs. So back to this diagram, what you normally have for while you're on the drug is a steady state. The drug is there, the body is used to this new level of neurotransmitters, and in general, people have a kind of new steady state. Now, if you stop the drug, and let's say you do it in the worst possible way, which is stopping it abruptly, the drug is removed from your body by your liver and kidneys over a few days or weeks, and you can see the levels dropping around quite quickly over a few days or weeks. The brain lags behind the levels of the drug. In other words, it takes the brain and body months or sometimes years to go back to its pre-drug state. It's if you will, its factory settings. And the difference between what the brain expects, the black line, and what the drug is inputting, that is the dotted line, is this shaded region, and that's what causes withdrawal effects. Yeah, a little bit like going back to my eardrum example, you walk into a loud concert, your eardrum adapts to the loud music, you walk out of the concert, and for a few minutes afterwards, sounds around you sound muffled. People, your friends' voices sound muffled. And it's good to understand that because the sound, that's actually a sound withdrawal syndrome. When you leave the concert, it takes only a second for sound to disappear as you shut the door. The reason why it takes a few minutes for sounds around you to sound normal is because it takes a few minutes for the eardrum to go back to its normal level of sensitivity. In other words, it's the time taken for the brain's adaptation, or in this case, the ear's adaptation to sound. That's what explains how long withdrawal symptoms can last. And similarly for exposure to antidepressants, it's not the time taken for the drug to leave your system, which might be a few days or weeks. It's the time taken for your system to get accustomed to the drug not being there, which can take months or years. And that's why people get protracted withdrawal syndromes that can make life so unpleasant for so many people. And many doctors don't understand how this could be because they say, how could you have any symptoms for a drug that you're no longer taking that's out of your system? And they fail to appreciate it's the adaptations to the drug and not the presence of the drug that causes the trouble. And so one way of minimizing the trouble caused by reducing these drugs is by doing it in smaller steps. So if this is the equivalent, I'll go back. Oh yeah, this one's fine. So this is going down step by step. So doing it in say 3 or 4 steps. The brain will still take time to readapt to lower levels of the drug, but the difference between what the drug is giving and what the brain expects is smaller. So this area under the curve, the shaded region, is less, and people get less withdrawal symptoms when they do it step by step. And even better is to make even smaller steps spread out long enough so that the brain has time to readapt to levels of the drug. And you can see that in this way, smaller steps causes less withdrawal symptoms. In fact, if you make small enough steps and you take long enough, you can make this process tolerable. To me, it's the difference between jumping off the top of a building, that's stopping it abruptly. This is like going down story by story, and this is like walking down step by step from the top of the building. It will take longer, but it will be a lot less trouble for your knees, or in the case of coming off antidepressants, on your brain and nervous system. And so the longer people take, the less trouble they tend to have with each step. Next slide. So the last thing to understand about coming off duloxetine is how strong the effects of small doses are. So this is a diagram showing a dose of duloxetine or Cymbalta on the x-axis, so 10, 20, 30, 40, and 60, off the right-hand side. And this is effect on the brain. It happens to be occupancy of the serotonin transporter, but actually this is true for any target, including noradrenaline or any other target of this drug. And the key point is, it's not a straight line, it's a curve called a hyperbola. In other words, 40 milligrams of the drug doesn't have twice the effect of 20 milligrams. In fact, there's not that big a difference. And tiny doses of the drug, something like, what's this drug here? 10, 5, something like 2 milligrams of the drug actually has about a quarter of the effect of 60 milligrams. So these tiny doses that sound homeopathic actually have much bigger effects than you would believe. And the reason for that is it's something called, the fancy pharmacological term is the law of mass action. But what it means in simple terms is when there's not much drug in the system, in the brain, every receptor for this drug is open for business, unsaturated in pharmacological terms. A little bit like, so every milligram of drug has a large effect, a little bit like the game of musical chairs near the beginning. All the chairs are open, and so it's easy to win the game. By the time there's more drug in the system, by about 20 milligrams, most of the receptors are already occupied by drug, and so every extra milligram of drug has less and less effect, like at the end of a game of musical chairs. And so you get this sort of law of diminishing returns, or this hyperbola. And this can help us to understand what happens if people reduce by linear amounts of drug. So let's say a well-meaning doctor who's not very well informed about this sort of curve says, well, why don't you go down from 40 to 30 to 20 to 10 to 0, let's say every couple of weeks. And the reduction from 40 milligrams to 30 milligrams doesn't cause that big a reduction in effect on the brain. 30 to 20 causes a bit of a larger effect. 20 to 10, larger again. And going from 10 to 0, which sounds like the same size step, is kind of like jumping off a cliff. You imagine walking down this curve. It starts off like a country walk, not very steep. It moves into a steeper hill and it becomes a cliff. And people fall off this last step and they end up in, sometimes terrible places with terrible withdrawal symptoms. And the doctor says, well, you must need the drug. You must have had a terrible relapse, because they don't understand that the last 10 milligrams are much harder to come off than the first 10 milligrams. And so what we've published about in the last few years, and it's now become the guidance in the UK, although not in America, is it makes more sense to reduce these drugs not by even amounts of dose, but by even amounts of effect on the brain. In other words, I've drawn 4 horizontal lines here at 20 percentage point differences. And this means that to reduce this drug safely, you need to go down by smaller and smaller amounts, down to very small doses before stopping. So rather than stopping at, say, 10 milligrams, you may need to go down to a couple of milligrams or even less, so that that final reduction to 0 doesn't cause a bigger change in effect on the brain as these previous reductions. In other words, as you're going down this steep cliff, you want to make smaller and smaller steps, like you're climbing down a cliff, step by step, all the way down to the bottom, rather than jumping off at 10 milligrams. And this approach is called hyperbolic tapering, because this is a hyperbola, a shape you might remember from high school. And hyperbolic tapering is now kind of the gold standard treatment in Britain, in the guidelines, but it hasn't yet been adopted by any institution in America. And it's the main process that Outro offers. Next slide, that might be it. So here's some examples to make this a little bit more tangible, because the graphs are a little bit hard to get your head around. Here is an example of what I would consider a faster taper of duloxetine. This would be restricted to people who'd been on the drug only, say, a few months, hadn't had trouble coming off it before, hadn't had trouble with other drugs in the past. So this is kind of the low-risk group. And you can see that coming down from 60 milligrams would involve, first of all, slightly larger steps, but when you're below 20 milligrams, smaller and smaller steps, all the way down to less than a milligram. And again, that's following that curve, so that when doses get smaller, you need to go down by smaller steps. And next slide. For people that had more trouble, this might be someone who's been on the drug a couple of years. They've had a bit of trouble when they've made reductions in the past. This is a slower reduction. Each of these steps would normally go for about a month. And so this reduction would take about 20 months. Of course, there's a little bit of adjustment for everybody. If people had trouble, they could go a bit slower. If people had no trouble, they could go a bit quicker. And again, you can see Reductions can be made a bit quicker at the beginning because the graph is relatively flat, and as you get down below 20, the reductions become smaller and smaller, so that by the end you're going down by a small fraction of a milligram at a time. And again, this should be adjusted to how the person responds. And then the final taper, here's an example of an even slower taper. This would be for somebody who's been on the drug for many years. They've had serious trouble when they've tried to reduce in the past, and this would involve about 40 steps, and that might take somebody 3 or 4 years to come off. Again, this is just a guide, and ultimately the rate is really the rate that the person can tolerate. So although I'm putting here together a lot of different pharmacological, technical work, ultimately what matters is how does the person respond to reductions? If they're having trouble, they need to slow down. If they're doing okay, they can speed up. And the overriding principle is that everybody's a bit different. We didn't go into it in great detail here, but there are some risk factors that we recognize. But ultimately, these are not perfect, and you need to adjust things to the individual, and really the right rate to go at is a rate that causes people to have no more than tolerable symptoms so they can keep on living their lives. And some people coming off duloxetine, I know, have taken 5 or 6 years. That's not unheard of. And there are some luckier people who can do it in a year or less. But I should say, in my experience with duloxetine, more people need to take more than a year or more than a couple of years to come off safely, because it can be such a difficult drug to come off. That might be the end. Great. So I might turn to Maria now and get a little bit of a flavour of what she's seen in moderating Cymbalta Hurts Worse. My first question is, I'm on Twitter. For anyone who wants to see me having my head bashed in, I'm at Mark Horrow. And I was on Twitter the other day, and a prominent psychiatrist who happens to be paid quite a lot of money by drug companies, incidentally, told me that I was making a mountain out of a molehill about coming off antidepressants, because psychiatrists and other doctors already know how to safely stop antidepressants. And I want to ask Maria, is that your experience with the group of people on your Facebook group? Are they saying that their doctors have been very helpful and very knowledgeable and made the process very easy for them?
Thank you for the question, Mark. We have over 38,000 members in Cymbalta Hurts Worse because doctors do not, for the most part, know how to get off this drug safely. They are not aware of anything you described around the necessity of a hyperbolic taper or how to do a hyperbolic taper. A lot of our members have been gaslighted by their doctors. They go to their doctor and say, I stopped this cold turkey like you told me to, and now I'm suffering these very many symptoms, and the doctor will not acknowledge that this is the result of stopping cold turkey or dropping too quickly. And so they end up with us in Cymbalta Hurts Worse.
So let me get into it a bit more. So let's start off at the beginning. So give me the kind of general story from your website. So a patient comes into their doctor and they say, I think I want to stop this drug. I think I've got some side effects. I don't want to be on the drug anymore. What do the doctors mostly respond with? What sort of advice do they give when patients say that to them?
Someone who was on 60 milligrams, they would probably say you can cut that in half, and 2 weeks later you can cut that in half, and then you can just stop. Or they'll go by what the milligram amounts that can be prescribed are. So you could go from 60 milligrams, you could combine a 20 and a 30 milligram and go to 50 milligrams. You could take 220 milligrams and go to 40 milligrams. And those, for the most part, are not working for the people we see because it's not the hyperbolic taper that you described.
So they sort of sound like they're doing kind of a very linear taper. They might go to 60, then 50, then 40, then 30, and the smallest dose they can get with the capsules are 20 milligrams. Is that what there is in America?
That's correct in the United States.
Okay, and so they'll tell people to stop 20 milligrams, or will they sometimes tell people to take a 20 milligram every second day as a way to soften the blow?
Both of those.
Both of those. Okay, so they're stopping either at
Uh,
20 milligrams or 20 every second day.
yes. And taking it every second day is, in my opinion, the worst way to come off it because it has a 12-hour half-life. So on the day you don't take it, you are at tremendous risk of very bad withdrawal symptoms.
I was about to say, it's, what happens with these drugs, as people probably know, it goes up and down in your system, and the less often you take the drug, the more up and down it goes. So for duloxetine, by 24 hours, you've almost got a quarter of your normal dose. If you do it every second day, you've got a quarter of a quarter. You can go down to 1/16. In other words, if you do it every second day, you have incredibly large changes and it can cause people terrible withdrawal symptoms. So it is a very unwise, risky way to reduce the drugs. Okay, so that's what the doctors recommend. And then patients come back and they say, I'm in a horrible state. And you saying the doctors respond and say it couldn't be the drug. What do they think that it is? What sort of things do they tell patients?
Uh, Usually just that it couldn't be the drug,
Yeah,
that you need another drug to soften the blow. So they will, which is often an interacting drug, and
right.
so it will actually make your situation much worse if you um, take two drugs that are affecting the serotonin receptors, even though you're on a lower dose of the first one. So, yes, that is one of the
So
many bad ways to come off the drug.
right. So it sounds like the doctors are kind of saying if they're offering other drugs, they're saying, and it's not coming off Cymbalta, it sounds like they're interpreting whatever they see as a mental health condition. This is their anxiety or their depression coming back. Is that kind of the general theme that you see?
It can be that, but then the drug can also be prescribed just for pain, so they think it's
Right.
the pain coming back.
Good point. Yes.
I
So
don't think it works very well for pain, but that's my lay opinion.
yes. So I probably should point that out. That's right. People sort of are used to Cymbalta being prescribed for anxiety or depression, but it's now used for pain, a lot also in the UK and in America. And it's because the company did a study showing that Cymbalta had a very minor effect on pain, I think at 3 months. Um, there was a recent study showing that the effects of most of these drugs are very minimal, especially in the long term. People are probably aware of the issue of tolerance, that if a drug does something in the short term, it generally wears off in the long term. And sometimes, a bit like opioids, drugs that can be useful in the short term can cause trouble in the long term. And Cymbalta may well be one of those sort of drugs. I find it a bit interesting when people who are put on Cymbalta for pain turn up to their doctors when they come off it and say they've developed terrible anxiety and panic, and the doctor says it's a return of their condition when they didn't have that before. I always find that a bit strange. Sometimes I've seen doctors say, well, coming off this drug has uncovered an underlying mental health disorder, sort of like there's this new disorder that's popped up out of nowhere that just happens to coincide with the moment you've stopped the drug. To me, it's a very fantastical explanation, but I think this comes because most doctors have not been educated that withdrawal symptoms from these drugs can be severe and are very common. And I think that's because they don't. So that's why they don't see these symptoms as withdrawal, because it's very hard to see what you haven't been taught to see. All right. So and what do patients do in this state? So they're in a terrible way. They've come in to see their doctors. Their doctors have said this might be a relapse or this is some sort of mental health problem. You need to go back on the drugs. And what happens to people in that situation? Do they go back on? And what do they do then?
Well, we don't know what they do before they find us at Cymbalta Hurts Worse, but quite a few people who come to us feared that they had to stay on the drug forever.
Right. Okay.
And it's a joyous thing when they find us, and we can help them very slowly, guide them on how to get off the drug. But we hear every week someone who has concluded that they have to stay on the drug forever.
Right. So I think that's a very common message given from doctors, but also just patients come up with that. they've tried to come off, they've ended up in a terrible state. The doctors told them this is a sign you must need your drug, or they've concluded the same thing. Or people have been told, they've got a terrible mental disorder like major depressive disorder or generalized anxiety disorder, and it's caused by a chemical imbalance. So you need the drug like a diabetic needs insulin. And when they come off the drug and they feel terrible, it confirms that idea. So I think there's this sort of like connection between this chemical imbalance conception of mental health problems and withdrawal effects that come together in this kind of vicious cycle where it convinces you that you need the drug. And I often, it's a slightly glib comparison, but I often compare this to thinking about, say, quitting cigarettes. If we didn't know about withdrawal effects from cigarettes, people would quit cigarettes, feel terrible, and they might conclude, I need cigarettes to keep well, to stay well. And your doctor might say to you, you better keep smoking because it keeps your mood even. That's an absurd thing to say, because of course we know that cigarettes are generally cause withdrawal when you stop them, and having trouble stopping them doesn't mean you need to take them. It means you need to come off them more carefully. But I think when it comes to antidepressants, we don't have as clear an idea because there's a lot more misinformation, I would say, around these drugs. But of course, just having severe withdrawal effects from coming off the drugs doesn't mean you need them. What it means is you need to come off them more carefully. And I think that's right, exactly as you said. Many patients are told this is a sign you need them long term, maybe for the rest of your life. And like you, Maria, I also take a lot of joy from showing people that they can come out of this if they do it more carefully. And so, I guess, what is the secret sauce then on Cymbalta Hurts Worse? What do you recommend to people coming off the drugs? What are the tricks of the trade?
Well, one thing we started about 6 months ago was we were looking at those hyperbolic curves. And we realized, okay, if someone's on 120 milligrams, they don't have to taper at 5% of the previous dose necessarily. They can perhaps drop straight to 90 milligrams. What we are experimenting with is telling people you might be able to do this because we're a lay peer support group. We are being very conservative and saying we only suggest you try this if you don't have a history of taking other psychiatric drugs, if you don't have a history of going into withdrawal from other psychiatric drugs, you have a really clean environment, so to speak. You're not taking a benzodiazepine also. And that was the best we could come up with for lay people because we are erring on the side of caution. We're still in discussions about suggesting bigger drops from 90 milligrams to 60 milligrams, similar reasons. We aren't medical doctors. We do a lot of hand-holding, but we see so many members who have been on and off all kinds of psychiatric drugs. And that makes everything they try to do to get off a drug more difficult because they may have a kindled nervous system. They've just had a lot of experiences that are tough on the nervous system.
And so, okay, so at higher doses, based on what you've seen, I guess in the Maudsley prescribing guidelines, you're recommending going a bit quicker. And what about at the end, that critical bit at the end, say at 20 milligrams, when doctors say you might just be able to stop it? What do you guys recommend at that point?
We're still recommending reducing by 5% of the previous dose all the way to the end. The hyperbolic curve would suggest maybe you should even go slower than that at the very end. And a lot of people, I should have mentioned the mechanics of how we taper Cymbalta are we open up the capsules where there are hundreds or dozens of beads inside, and you can make very precise doses by counting out the number of beads and reducing them very precisely, usually every 2 weeks, sometimes longer. And so once you get down to having 15 beads in your capsules, we're going to suggest you drop by 1 bead at a time, maybe 2 beads at a time. Listen to your body. That is so critical. Just listen. Listen to your brain and your body and check in with us if things aren't going well. But that's how we deal with that tough end game of the hyperbolic curve.
Okay. So
Maybe you have better ideas.
no. So just to get it right, so you guys basically recommend going a little bit quicker, making bigger percentage reductions at higher doses because the curve is kind of flat there. At the low end of the curve, it sounds like you're recommending going down by 5% of the dose every couple of weeks. And when you say 5%, you mean of the most recent dose. So the reductions get smaller and smaller. So 5% of 20 is 1 milligram, but 5% of 10 milligrams is only a half a milligram. So you're getting smaller and smaller reductions. And what you're doing, I think, is very clever because you're approximating the shape of that curve. And I always found that, that was a big moment for me in my life when I found that the imaging of the curve that I've just shown in that graph matches almost exactly with what people worked out really by trial and error on peer support sites, that if you put them side by side, they're almost identical. To me, that was like finding that the coastline of South America and Africa fit together, and that the continents moved apart. That was a spit my soup out moment in my otherwise boring and sad life. So, and the way you're doing it mechanically is you're getting people to count beads, remove 5%, put it back in the capsule and swallow it, and that's how you make reductions. And at some point, you can only remove 1 bead every couple of weeks.
I need to correct one little thing you said
Please
about how
do.
we do it.
Yes.
The capsules don't have the same amount of beads in them because they're filled by automated equipment. And when we start tapering, we compute the average number of beads in 3 capsules. Then you start your taper at that number, and then you get very precise with your reductions in the number of beads is how we go. So
Yes.
small little selection.
Right. And maybe it might be obvious to many people in the audience, but I'll just spell it out. So one of the reasons that Cymbalta tapering is so difficult is because duloxetine, the active ingredient, is gastrosensitive, which means that it's broken down by the pH in the stomach. So if you crushed up these beads or you made a liquid, you wouldn't get active duloxetine delivered to your system because the stomach acid would break it apart. And so these beads are covered in a gastro-resistant covering, which means it will get you through the stomach and will only break down later on and release the drug when you're past the dangerous acidity of the stomach. And so that's why tapering duloxetine or Cymbalta is more difficult than other drugs, because other drugs, some of them you can make up as liquids, you can crush them, you can make up suspensions. You can't do that with Cymbalta. And that's why really the most practical way to do things is to count the beads or weigh the beads using the technique Maria said, making some averages, making some approximations, and putting them back in the capsule. I think I've heard some murmurs from some compounding pharmacies that they can do something to put a covering on it so that it will still be delivered. But one of the simplest ways is to count or weigh these beads and to recapsulate them. That's interesting to hear, Maria. And can I ask, what sort of problems do you see as people go down in their dose? What kind of issues do they bring to the group, and what sort of troubleshooting do you guys use?
How long do we have? No, I'll just start talking.
All sorts of
Some of the most common mistakes we see from members who come to us are the doctors who are having to make the very large drops. Oh, and also another thing medical doctors like to do is replace Cymbalta with another antidepressant or psychiatric drug. And that will not necessarily stop withdrawals from stopping Cymbalta cold turkey. And then you're still on another bad drug that you're going to have to taper off. So switching to a different drug is something doctors frequently recommend. That the experience of our members is that it doesn't really help, Another issue we are having are brand changes. People are not always aware when they pick up their new repeat or refill that their brand changed, and that might mean that the number of beads inside your capsule changed. And so you are going to need to, short version is figure out what percentage of a full dose you were taking of your old prescription, and take that same percentage amount of beads from in your new prescription. Mark, because people get so brain fogged on this drug,
Yeah.
that can be a very hard task for people to accomplish.
Right.
And
Yeah.
we hold hands and we help as best we can. I'll also say the state of math literacy in the English speaking world is not very good either. But we know math and we can help. So the brand change, and then we also, when a brand changes, we suggest that people hold their dose for 3 or 4 weeks to make sure they're not reacting badly. So then it, sets their taper back a little bit. We also have had some recalls of lots of duloxetine and Cymbalta recently that have caused more brand changes to be happening. So I could go on and on. What's your next question?
I'll pick up. Actually, I want to say one thing. If anybody has any questions in the chat, please put them in, and I'll try to answer them, or I'll put them to Maria.
Oh my
If we
goodness.
have a few minutes. I wanted to pick up on two of the points you just made, Maria. So one is switching drugs. So in the textbooks, it kind of says you can switch any of these antidepressants to another antidepressant, and you can do it in a few days or a few weeks. And so doctors kind of do this. They often, I feel like I was taught that switching antidepressants is like changing the color of paint on a wall. Put up blue one day, if you don't like it, change it to red, no big deal. But I don't think that's the case. I think switching antidepressants is a very big deal. And part of the reason why is that every antidepressant, although they're from the same classes, SSRIs or SNRIs, there are differences between the receptor targets of each drug. And if the targets are not identical, then there's a change that the body experiences. So if a drug affects serotonin in a very strong way and noradrenaline in a medium way, and you switch to another drug that doesn't affect noradrenaline, you can get significant withdrawal symptoms from the noradrenaline or norepinephrine in America uh, differences. And so, yes, switching, which looks like a dream in textbooks, is often a nightmare in real life. I'm glad you put your finger on that. And on the topic of brand changes, I think that really, and I have the same approach that your group takes. It's good to be conservative with everything. I think these drugs, have a very strong effect on the brain. They can be very hard to stop. They're sometimes treated as harmless as Tylenol, but I don't think that they are. And so if you make any change, it's better to do one thing at a time. So if you change brand or you change formulation, it's good to do that without changing your dose. And even to do that in steps if you can, so you're breaking it down into smaller steps rather than jumping in the deep end, you're putting your toe in. And when you've done that and that's fine, then start making reductions. So you don't want to ever be doing two things at once, because then it's very confusing to know which thing is causing which problem. So I think the way your group approaches it is very sensible. So maybe I'll my final question to you, Maria, before we maybe look at some of the questions in the chat, is what would be, if you had to give 3 tips, or you had a minute before the elevator came, what would you say to somebody who wanted to come off Cymbalta? What would be your 3 takeaways or hot tips?
Join the Facebook group Cymbalta Hurts Worse. Pay attention to what the moderator suggests that you do. And if you run into trouble, let us know right away. We aren't medical doctors, but we have probably seen the issue that is troubling you before, and we'll probably have a suggestion on how to help you feel better.
And would you say that the kind of best approach that summarizes what you guys do is to do it very slowly over months and years, make small reductions and adjust things based on your symptoms? Is that the kind of general principles you guys use?
Very much so. We want you to be able to live your life, to keep your job, to keep your marriage, and to keep your kids.
Okay, that's some pretty heavy things. And would you say, I guess, to give hope, there might be people in the audience who are thinking about coming off or are just starting. What would you say a good taper looks like? What have you seen examples of people that have followed all this advice, done it gradually, adjusted it if they got into trouble, and essentially had a fairly smooth route coming off?
We do, and they don't post much in the Facebook group. And
Right.
so if you come to the Facebook group, you are going to see a lot of misery. But then someone we haven't heard from in a year and a half will post their celebration of being off the drug. And then it's a happy day for everybody.
Right. So in other words, it's the sort of the people who go too quickly or who make errors are the ones who sort of make the most noise because they're looking for help. And there are people who are not so voluble in these groups that are going step by step, doing it slowly, following this 5% every couple of weeks that basically get through the process without major issues.
Exactly. Exactly. And they have no reason to contact us until they want to have their celebration, and we're thrilled for them.
Right. So I see the same thing, that people that do this process and are patient and make small adjustments and don't become impatient and speed up can have a fairly tolerable experience coming off the drugs. And the people that I see get into most trouble are people that try to speed up. Very understandable. Everyone wants to come off these drugs, so I understand the impulse, but I often think that tortoises beat hares. That there's this kind of a theme that I see repeated again and again. Okay, okay. So there's a few questions here. So I guess this is a question for Maria. Does Cymbalta Hurts Worse also help people come off other SNRIs like venlafaxine or Effexor?
We do not, but we can suggest a different group that could help you. And we don't mind if you post and ask that question. We will be happy to give you that information.
That's fine. So this is a question. A doctor has proposed to me to use microdosing of ketamine to help come off Cymbalta. Will this be problematic? In other words, you can't hack the need for hyperbolic tapering. Look, I think you've got an intuition there of what is happening. In my experience, if you use another drug to make the process easier, often what happens is you're switching drugs rather than stopping drugs. So, for example, I've seen people who are coming off a drug like Cymbalta and having a lot of trouble, and they'll say, I found another drug that makes withdrawal symptoms a lot better. And that drug might be Valium or Xanax or Ativan or another antidepressant, or it might be ketamine. And in that case, what I think is happening is it probably is true that the drug is improving withdrawals. It's probably by adding on a bit of sedation or a bit of euphoria or the effect of the other drug. And what tends to happen is you do that, you're using now the second drug to make up for withdrawal symptoms from the first drug, and you'll become dependent on the second drug as you reduce the first drug. And so you sort of switch drugs rather than stop them. I kind of call that robbing Peter to pay Paul, because you're going to end up having to pay, you've got debts now with Paul, so you might find you become dependent on ketamine. And in my experience, that the easiest way to come off these drugs is to do it slowly at a rate you can tolerate, being very careful at the end, which is what hyperbolic tapering kind of entails. And I don't really think there's a shortcut. I think everybody wants a shortcut or a magic bullet, but I haven't seen that work. Maria, do you have a comment on that?
Our position at Cymbalta Hurts Worse is that ketamine is a very risky and dangerous substance to ingest. And I'll leave it at that.
And in general, say with other drugs, if people start using other drugs to manage withdrawals of Cymbalta, how do you see that end up?
If it's a prescription drug not well, less is more.
Yes, yes. I often see people end up becoming dependent on that second drug. Maybe we've got time for one last question because we started a bit late. So the question here is, my psychiatrist uses Prozac or fluoxetine to help come off Cymbalta, but I have no experience with this as I have yet to start tapering. So this commonly comes up. It's called the Prozac bridge. And the reason why this comes up is about 20 years ago, the manufacturer of Prozac did a study that was quite devious, I would say, or clever, depending on whether you're invested in the company or you're taking their products. What they did was they got a whole bunch of people on different antidepressants to stop their antidepressant for a week, and they measured withdrawal symptoms. And what they showed was that many antidepressants caused terrible withdrawal symptoms, but Prozac didn't. And so they put out a lot of marketing saying Prozac is very easy to stop. In fact, people who are on other antidepressants might switch across to Prozac and come off that way, and they called it the Prozac bridge. And they did that study because Paxil was starting to become the blockbuster and it was taking their market share. Now, the reason why that study is clever or devious is fluoxetine or Prozac takes a longer time to leave your body than other drugs. It takes about a week or two to go down to half of its level, whereas other drugs takes only a day normally. And so if you stop the drug for a week, it doesn't have time to go down to low enough of a level to experience withdrawal symptoms. And so withdrawal symptoms from Prozac tend to be delayed by 4 or 6 weeks. So they took an early snapshot and they showed no withdrawal symptoms. And that allowed them to say that our drug has less withdrawal than other drugs. It probably is a little bit true that Prozac has a bit of a self-tapering aspect to it, but it's not completely true because the withdrawal effects tend to be delayed, and we know that about half of people who stop Prozac will also have trouble. So I think the Prozac bridge is based on this study that is very misleading. You'd say in Britain, in America, you might say it's dishonest. And what I've seen is that switching across from Cymbalta to Prozac causes people terrible withdrawal symptoms because Prozac doesn't affect noradrenaline or norepinephrine. And so you get a withdrawal effect from part of the receptors that Cymbalta affects. And so the switch can be difficult. If you do get across to Prozac, and sometimes I call it a bridge to nowhere, because people have trouble coming off the first drug, they end up on both drugs. So they kind of get trapped between two. They're on Cymbalta. Because they get withdrawal symptoms when they come off it, they go back on Cymbalta. And because they've been on Prozac for a few weeks, they might stay on Prozac as well and end up now with doubling their problems. Let's say it does go well. You now have to come off Prozac. And although this study said it's very easy to come off Prozac, coming off Prozac is itself difficult. And it can take people a year or 2 years and have the same kind of difficulties as coming off Cymbalta, although maybe not quite as severe. In other words, you've now given yourself several problems, the switching problem and the problem coming off the drug. So in general, I find it's easier to come off the first drug than to switch to another drug and try to come off that. So I generally think this technique doesn't work. There may be cases of it working, but I've seen more people get into trouble than not. And I'd be interested to hear Maria's perspective.
Well, there's also the risk of serotonin syndrome if you're taking 2 drugs at the same time that affect serotonin, which Prozac and Cymbalta both do. So I don't see Prozac contributing anything of help to getting off Cymbalta.
Normally, Prozac and Cymbalta don't together cause serotonin syndrome because they're both affecting the same part of the receptor. Normally, serotonin syndrome is when drugs are affecting 2 different aspects of the serotonin transporter or the serotonin system. But you're right, they're both affecting the same system. And I agree that in general, I don't think it's the best approach. All right. So we've tried to make up for starting late by sticking around for a few extra minutes. I can see there is actually quite a lot of interesting questions in the chat, which we won't have time to answer now. We'll have future webinars, and we'll save these and try to address them in future webinars. This webinar is being recorded and will be uploaded to the Outro website soon. And we will have follow-up webinars focusing on different antidepressants and other related topics. And I want to say especially a big thank you to Maria for joining us today to give us her insights really from the coalface, from seeing thousands, actually tens of thousands of patients, more than most medical doctors, and sharing with us some of her insights. So thank you very much, Maria. Ooh, who's muted?
It's just been a thrill to be here and to get the message out to so many people. Do feel free to come to Facebook, join Facebook if you're not on it, and come to Cymbalta Hurts Worse. OTRO also provides medically supervised services to help people get off antidepressants. So they are also available to you. And this has just been a real treat to be able to hopefully help people and get the word out.
Thanks, Maria. Next time when you come back, we'll have to make sure that we can see you so that people see
Yes, I
a
don't.
face,
This
a face to the voice.
I do have a face. It's lovely.
A lovely face. I've seen it. It's very pleasant. All right. Good night, everybody, and good afternoon, and good morning.